Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Hey, thank you so much for joining us and becoming a part of our little family, our little ohana. I hope that you're finding yourself well on this beautiful day in Hawaii. One of the things that we're going to talk about, well, we talk about a lot of things. Vein Clinics of Hawaii, Dr. Juliff, on 4 islands. On the Big Island. Started on the Big Island. Funny, huh? Usually it starts on Oahu and grows to the neighbor islands. In the case of Vein Clinics of Hawaii, it was the other way around. But we're glad to have them here, and every now and again we get together and record a couple of these shows. You cannot participate in this show, but you can contact us at veinclinicsofhawaii.com with questions. We do a mailbag every now and again, and we also have some myths and some things to do, but mainly it is to introduce a lot of people that are affected, are deeply affected at their ability to enjoy life because of issues in their legs. Usually these things are vein disease, and you've heard about this before, and Dr. Juliff has been practicing this for an awfully long time, and we're going to talk about that. Deep venous thrombosis. You see these things advertised on TV all the time, Doc. So in some respects, a little knowledge goes a long way. In some respects, it's like, don't be an expert by seeing an ad on TV and thinking you got DVTs all figured out. What is a DVT anyway?
Well, DVT stands for deep venous thrombosis, and typically people refer to those as blood clots, and usually they happen in the legs. And the reason that I wanted to talk about it in particular today is because March is always DVT Awareness Month. Which is a very, very good thing, because there is a lot that, lay people can be aware of when it comes to, their risk of developing a DVT or, what are the signs, et cetera, that can really help avoid maybe DVT in the future for them, or at any one particular point, and that's why the marketing that goes on, particularly for blood thinners, mainly is what we see on TV.
Is it my imagination, or just it's just a huge new number of these things out there?
Yeah,
with all weird names.
Right. Yeah. Well, you're right, because in more recent years, a whole group of new blood thinning medications have come out. For years and years, we had something called Coumadin, also called warfarin, and that was the only blood thinning medication that we had in pill form to treat people with, and that's the medication that often people refer to as a rat poison, because basically it's very similar.
Especially when you read those some of those. By the way, you might have suicidal thoughts. I don't want them.
Yeah.
But
so there's been a new group of blood thinners, and consequently a whole new group of advertising for that. And is that bad? Well, no, not necessarily, because of the fact that at least it helps people become even more aware.
I'm thinking it's good.
Yeah.
I do know that sometimes in our industry, in the broadcast industry, you'll hear the term, if it bleeds, it reads. In other words, and then sometimes people will watch these commercials and think, okay, weigh the pain. In other words, this thing might cure me, but it also might do this. So what I really want to do, now that I've seen it on television, and I see the ads are very, very akamai the way they work. Yeah. Because they say, see your doctor.
Sure.
And then now I come see you and say, hey, Doc, I saw this stuff. Is it going to be good for me?
Yeah. Or what they really want you to do is they want you to go to your doctor and they want you to say, hey, this is the one I want.
Yeah.
So, that's why I think we're hearing more about DVT, and again, I think that's a good thing. But blood clots in general the first question always is this a good thing or is it a bad thing? And
you kind of need it, don't you?
Yeah, right. It can be good and bad because our body relies on blood clotting in a lot of different situations for our own good. Just down to if we cut ourselves with a knife, cleaning fish or whatever. If our blood didn't have the ability to clot, then that cut or whatever it was, no matter how small, would just keep bleeding, indefinitely.
Sure.
But typically what we do is we put a little pressure on it and hold it for a while, put a Band-Aid on or whatever, and then ultimately it stops bleeding and the skin heals. But so that's the good part of blood clots. The bad part of blood clots is sometimes they happen in areas and in situations where we don't want it to happen. Yeah. And
we're typically, now, if you're talking about a blood clot in the leg, one thing that I've learned over the time, gang, is that don't be confused with the little clot you have on your finger when you cut yourself while you're, chopping vegetables. That is a clot, but I've seen some of these things on ultrasounds of me and of other patients where this thing can be long. It's not just a little tiny clot. This thing can be a couple of feet long. That's kind of scary.
Yeah. And those are the ones that can, cause a lot of problems. Including can be fatal, But the blood clots that occur in abnormal scenarios, they typically happen in veins, and that's basically what is referred to when we talk about deep venous thrombosis. And if the clot can essentially fill the size of whatever the size of the vein is, some veins in our legs are very small. But some veins in our legs are pretty good size. They can be the size of your finger or more.
If you get a clot in one of those veins, isn't it pretty serious?
It is, yeah. And not only is it the size, but it's also kind of the location. The further up your leg you develop a blood clot, the worse, because it's, blocking the flow for, a much greater, volume of your leg. So, it can be significant. No question about it.
What I'm thinking, though, is that once again, referring to these TV things, it gets to a point where you almost get, blasé about it because there's just so much of it out there, and it seems like it's break after break after break. Yeah. But in retrospect, I'm thinking, because I've had people say to me that listen to our shows, that they heard the show and then they saw a couple of these ads, and whatever it did, it made them go to their doctor. So this is, I guess, what they're trying to do. But interestingly enough, and let's, while you talk about March being, Deep VT, Awareness Month, let's take a look at the rush there is in the virus research to find a vaccination and then a cure. How many people come into your office in the initial visit say, what medication do I take to make these veins go away? Yeah. I mean, isn't it interesting? Your profession is saying that at this point in time, there really isn't a magic. There really aren't pills that will cure vein disease.
No, there isn't. Yeah. Venous insufficiency, just in general, it's a mechanical problem. The veins aren't moving blood adequately enough and in the direction that it should be, and that's from faulty valves, and again, so that's a mechanical problem. There really isn't, there's not a medication that's going to alter that tremendously. And
we'll get into a little later in the program, guys and gals. We'll get into something, and that is, can actually some medications contribute to a clot? Can they make things worse?
Sure, right. And then the other thing that people always ask is, what about diet and exercise and that kind of thing? And unfortunately, the answer is the same. There really isn't anything that you can do with respect to those types of areas either that is truly going to impact the health of your veins if your veins are failing in their function. But why does blood clot? Well, blood clots, the reason that we have that mechanism within our body is to stop bleeding when we need it to. But is there a potential for overclotting? Yeah, there is, and that's one of the reasons why blood clots might form at inappropriate times or inappropriate locations. So how does a blood clot form? What exactly are we talking about when it happens inside your body or on the surface?
Is it like everything else? It starts off being really small, maybe even hard to detect.
Yeah.
And then later, untreated or undiagnosed, it can get bigger and become a problem.
Right.
Yeah.
Right. And it's a combination of a particular type of blood cell. In our blood, we have something called platelets, and many people have heard of platelets. But platelets are important in the clotting system because platelets are one of the first things that happens when we cut ourselves or there's tissue damage. The first thing that happens in our body is that platelets kind of become attracted to that vascular injury.
Pretty magic, isn't it?
Yeah,
it is.
It really is.
Wow.
Because it's all kind of chemically related, and so platelets congregate in that injury to the vessel and form what we call a platelet plug. And basically, that's our first line of trying to get bleeding to stop. So that's one part of it. The other part of it is a system of proteins within our blood. We call those clotting factors, and these are standard type of proteins that are made in the liver, and they're circulating throughout our body all the time in an inactive form. And as soon as an injury happens to a blood vessel, then again, there's chemical activations that happen, and these clotting factors convert from an inactive to an active form, and one acts upon another, and eventually then creates thrombin, which is the final product that then creates a clot to form, blood to coagulate and a clot to form.
And I've learned, and we've learned on previous programs, when we talk about these things, each one of them has its own personality and its own story. They may look the same, and I'm sure that you've seen every possible clot there is, but isn't it amazing how many there are? I mean, I just was fractured when I saw in doctor's office. I saw this diagram, and it shows a diseased a diseased leg, and this clot is really, really long. I bet you some patients, when they find out just how, they're going to say, geez, how long did it take for that to happen? How bad is it going to get? What do I have to do?
Right. Well, they can, if the process continues, the clot just keeps getting bigger and bigger. And that's one of that. Well, that is a big part of the reasons that we put people on blood thinners is to stop that progression of the clot, because often it will start in a kind of a local area, and then increase in size. And as it increases in size, it becomes more and more significant.
When they start to come apart a little bit, some of these concerns that you have, that they go in, a clot starts to come apart and gets up into your heart or into your lungs. That's where it becomes a big problem.
Right.
Is it always from the top of the clot that happens? I'm thinking that,
typically it's going to be that part. Or if not the entire clot, I guess the entire clot can become, mobilized, and
that's scary.
Yeah, well, it is. It is.
Entire clot, right?
So some of these bigger veins in the upper leg and in the pelvis, and again, they're the size of index finger and even bigger. So that's a pretty big, clot volume, and those things can break loose. And when they do, they follow the circulation up through the heart and then into the lungs, and that's something that people die from. There's no question about it.
And so we don't want to scare you, but I mean, that question always comes up. And when you see that, that's in some of the medicines we're talking about that show these disclaimers that they might cause death. But isn't it also probably true that if you don't get them looked at or diagnosed, you're never going to know? I mean, you don't want to be afraid of something because it might do something. You want to say, well, what if it works? I mean, wouldn't that, the concept is, what if it works and I can go about my life?
DVT, with respect to whether you might know or do you know whether you have it or not, typically you do, especially if it comes on pretty suddenly, because there are, specific symptoms that are, in most of the time hard to ignore. So most people know that something has happened.
Now, the symptoms don't always necessarily mean pain, right? I mean, it's some form of discomfort, but maybe not throbbing, hurting pain.
Yeah,
you know?
yeah. Kind of like what we've talked about before.
Heaviness.
People have different ideas about what pain is, but yeah, pain is pain of one sort or another, and swelling are the two main symptoms that people might have if they develop a DVT.
Got it.
So,
yeah, interesting because when it says on a scale of 1 to 10, and I say, well, I'm 6. But my 6 and your 6 might be different 6s.
Yeah.
So that's something you got to work through, isn't it?
Yeah, absolutely. So there's something called Virchow's triad, and this is a medical thing, but it's interesting because Virchow was a pathologist from the 19th century, and old guy, obviously a German. And he was pretty smart guy and a little bit ahead of his time, but he came up with the idea that 3 things happen that bring about a situation that puts you at risk for developing a blood clot. And the first is stasis, meaning that for whatever reason, the blood flow through that vein is not happening at a speed or a rate that it usually would safely do. So, it's kind of like...
Is it always slower?
Yeah, right, okay. Right. Stasis means that it's, slowing down. So it's kind of like a stagnant river water, So the river isn't flowing and the water is kind of standing in one place. And so when blood becomes static, when there isn't movement in that blood, it becomes more likely to clot.
Okay.
So, that's one of those 3 things. They call it Virchow's triad because there's 3 things. The other one, or the next one, is intimal injury, meaning there's some injury to, tiny little blood vessels. Well, not tiny, any size blood vessels, but the inner lining of that blood vessel becomes damaged in one way or another. So, either you've cut yourself or you've had a, blunt trauma, anything that's going to disrupt those little blood vessels, the inner lining of those blood vessels is going to, ultimately cause clotting. And what happens is a chemical reaction, again, kind of like what we were talking about before. The intima is injured or disrupted, and that kind of sets off a chemical reaction that then makes clotting more likely. And then hypercoagulability. And what do we mean by that? Well, we mean a state where blood is more likely to clot. And, though that has to do with, some medical problems like heart disease, cancer. Cancer patients are a little more likely to clot. Pregnancy. People, when they're pregnant, they are, by definition, hypercoagulable. The women who are pregnant, their blood is going to clot a little more easily than otherwise. So those are the 3 things: stasis, injury to a blood vessel, and a hypercoagulable state that then makes people more likely to develop a DVT in a inappropriate sort of fashion.
Okay, now there's lots of, like I said, there's lots of things we're hearing about. There's this one ad in particular where this lady is walking and is talking about a DVT, and you might get another one. And then she goes around the corner and the kid jumps in her. Everybody's happy, and she obviously didn't need another one. But is that something that is likely, if you are one of these people that gets them, are they likely to recur even if you have them treated?
Yeah. Yes. Basically, yes. If you've had one DVT, your risk of developing a second DVT is more than the general population.
Is it sometimes, however, a wake-up call?
Yeah.
I mean, that, hey, what is this? It's a DVT, sir. What are you going to do? I'm going to take it out. We're going to get rid of it. And then what?
Yeah. Well, it is important. And the question there is why? If somebody develops a DVT, the thing that they have to be asking themselves is, why did this happen?
Yeah.
Well, often there's a reason. Often they were on a long plane ride.
That was going to be my next question.
Yeah, like we've talked about a lot. They have some medical problem, or they had surgery. For instance, orthopedic surgery is notorious for people developing DVT post-procedure. I was just talking to a patient in the office yesterday that had knee surgery, and then after they had their knee surgery, they were laid up for a while, and then, a week later, they developed a DVT. So, there are those situations. Now, so that we are actually a little more comfortable with those because there was a reason.
Yeah.
And, so we treat those people with...
in other words, it's kind of likely to happen if you line up a condition.
Yeah.
That could very well could result in a DVT.
Right. Yeah.
Okay.
So a patient comes in with a blood clot and they tell us, I just flew over from New York or whatever, and we can say to ourselves, okay, good. Well, that's the reason. Yeah. We treat the DVT. They stay on a blood thinner for 3 to 6 months, and then we stop the blood thinner, and we feel a little more assured that it probably won't be a problem again in the future, since there was an inciting event that happened that caused that DVT.
Interesting too to me is that, once again, going back to these commercials that they're barraging us with, is when they talk about it, don't stop taking this without your. In other words, just because you start feeling good,
right,
or you can't find your prescription or your travel, I'll just get some more when I get back. That's not a good idea, is it?
No.
Yeah.
And it particularly applies to blood clots because you get put on a blood clot and your body starts to break the clot down, and the symptoms go away, and then you're saying, gee, I don't really need this medication anymore. Well, no, there are set protocols. There are set periods of time that somebody should be on therapy for a DVT, which we have learned just from experience and statistics and studies, et cetera, et cetera. So, there is a specific time. Now that is with respect to when the DVT happened. Having a reason is as opposed to people come in and they have a DVT, they have symptoms and they've developed a DVT, or they have very few symptoms and they come in and we find that they have a DVT. That happens too. But if they don't have a specific reason why they have developed a DVT, then we're a little more uneasy about that.
I get it. I get it.
So
Sure.
It takes a little more investigation and a little more of a thought process to determine how long should you treat that patient. Number one. Number two, is there a genetic component? We have to ask about family history.
My mom. We have to ask about my mom.
Yeah, exactly.
Really,
did your mother or your father ever have a blood clot? And if the answer is yes, and I have 2 brothers who had blood, well, then maybe there's something more there. And what I mean by that is, if there's a strong family history, then often we need to investigate that patient more to see if there's a genetic reason why they may have developed.
And I'm going to ask you how do you do that? Because I'm going to say, what if you have siblings and mom or dad had tremendous DVT problems, and one son gets it, the other doesn't. Yeah, he's still susceptible. So maybe that guy can learn are there steps that we can take out front of this thing to prevent them. I don't know if that's the case. And by the way, if you think, who is this guy talking on the radio with Mike? It's Dr. Randall Juleff. He's the medical director of Vein Clinics of Hawaii. This show is coming to you as a public service by them to get you aware of venous conditions. Today, we're talking about something called deep venous thrombosis. But if you have heard something that you need to hear some more about, or if you have a question about veins or issues that have nothing to do with what we're talking about today, you can drop us a line easily by going to veinclinicsofhawaii.com. veinclinicsofhawaii.com. Contact us, tippity-typity, and if you want to hear something on the show, you let us know, and when Doc and I can get to it, we most certainly will. We could literally fill up hours on these things, because is there a heightened awareness because of the TV? I got to come check. I think I might have a DVT.
Yeah, definitely. Which again, I think that's good. That's good because, especially with something like DVT, because it kills so many people. people across the country on a yearly basis, needlessly.
Yeah.
It really does. And but getting back to the whole family thing, what do you do? Well, there are genetic reasons why people might be hypercoagulable, and we call those inherited thrombophilias. Well, that just means that you inherited a propensity to develop blood clot, or your blood clots a little too easily. And so probably the type of inherited thrombophilia that is the most common one is something called factor V or factor V Leiden mutation. A lot of people have heard that before because they either have it or the family member has it. But there's a whole host of different types of genetic things that can lead to your blood clotting easier than it should. So since it's a genetic trait, then the question is always, well, is it our genes come in pairs, and is there one gene or is there two genes having to do with that inherited problem? And if it's two, then it makes the problem a fair bit worse. But is there a way to test for all of that? Yes, there is. So you go through genetic testing, and we can figure out whether those genes are present that make your blood clot at a higher level than it should. And then we can make, getting back to that patient that doesn't have an obvious reason for developing a blood clot, if that is if you've had a blood clot and there wasn't a specific reason, then we need to look at things a little more closely. If they have a family history, they need to have additional testing. And then it will probably impact their therapy too. A lot of these people will come in and they'll have a blood clot, and then you talk to them more, and it's like, oh well, yeah, I had a blood clot like 10 years ago too, and neither one of them had a specific reason for developing.
Do some people really not realize they're just encumbered, or they can't get around, or they're sore, they hurt? They don't think of that. They don't know what is. I'm just getting old.
Sure.
I remember my dad used to have trouble walking out to the mailbox. My turn.
Yeah. So we there's a number of different things that we have to think about when presented with a patient with DVT, and then on the other hand, there are genetic factors that make the blood more likely to clot. Well, there are genetic factors that control overclotting. The same way that we have protein clotting factors in our blood that create blood clot. There are proteins in our blood that control the overclotting of our blood. Because if all we had was a clotting system, then if we cut ourselves or had a reason for activation of that clotting system, then all of our blood would clot. There's no control. There's no buffer. So there's a whole system of these anti-clotting kind of proteins, and so people can actually have genetic problems that have to do with abnormal function of those proteins that protect against overclotting. And if you have a problem with that system, then that's going to let the clotting system become too active. So
I'm thinking though, when we started the program today with Dr. Juleff, by the way, medical director, VeinClinicsOfHawaii.com, VeinClinicsOfHawaii.com. We're talking about this in a sort of restricted travel industry right now, and as this becomes more of an issue, I would expect that some people that when some of these things you say come on pretty quickly, and maybe after a flight, are there something that somebody, when they get up at the end of a plane trip, say, geez, this is no good, and here I am 3,000 miles away from home. Where do I get some help for this?
Well, in like I said, usually in that kind of situation, the patient's going to have symptoms, and pain and swelling are the most common ones, and especially if you at the end of a long plane ride, you have pain in like just one leg. Well, maybe you've been, sitting wrong or whatever, and
that's what you rationalize. You think, I must have been sitting wrong.
Yeah. So, So, and again, that kind of falls under the topic of being aware, awareness, and which has been good because people have learned more about that kind of stuff, and so consequently, if you have those kind of symptoms, does it need to be looked at right away? Yeah. Should you wait till tomorrow or next Wednesday when you go home or whatever? No, it needs to be looked at right away.
Yeah, and there's another thing, gang. I want to tell you. And I've learned over the years from Dr. Juliff about this, that is most modern urgent care places or emergency rooms now have this ultrasound. And I'm wondering how soon in the game is an ultrasound check needed to find out, is this a clot? And if it is, where is it? And what are we going to do about it?
Yeah.
Is that part of the deal?
Yeah. And the answer to that is yes, right away. If people have symptoms, especially in that kind of setting, where you're immobilized for a while and, now you've developed leg pain, you really do need to go to wherever, either an urgent care or an ER, or to your doctor if your doctor is around. Because ultrasound is done so, easily and ubiquitously that it's a pretty easy task to answer the question, do I have a DVT or not? It's important to, if you do, it's important to start treatment right away because like we talked about before, the big part of the reason why we put people on blood thinners is so that clot doesn't get worse, and it will. It will propagate. It might start behind your knee, but if you don't get treatment, and especially a lot of these people, if they do have leg pain, then they tend to go home and go to bed. So now they're even more immobile.
There's another thing too, and that is, I asked earlier, gang, and if you're wondering about the difference between what you and I might think of what a blood clot is. Once again, the analogy where I cut my finger chopping celery, and it bled a little bit, and I washed it out, and I put a Band-Aid on it, and later on I took the Band-Aid off, and there's a nice little clot there, and everybody's happy. But the clots that we're talking about are really much larger.
Yeah.
And when I asked you about, what's that threatening? I thought maybe it was just a little teeny hair of it at the top broke off. But what you're saying is sometimes the whole thing can get moved.
The whole thing can do
and
that,
where is it heading? It's going up. It's going up into your lungs. It's going into your heart.
Yeah. Well, it goes
your brain maybe.
It could, but not usually. There is a situation where a blood clot like that starts in the veins actually can go through into the heart. Yeah. It has to go from one side of the heart to the other because
thank goodness.
And usually that's not the case. Although it does happen, I've seen it where people have had a stroke due to a blood clot in a vein. But typically what happens is that a blood clot from your leg or pelvis is going to break loose, and then it goes through the very large vein that goes up the middle of our body. It's called the vena cava, and the vena cava is a huge vein, and then that is what then leads into the heart. So it's on the right side of the heart. Now, the heart there's a right side and there's a left side. Right side has to do with lung circulation. Left side has to do with the circulation to our body. But basically that blood clot's going to go through the vena cava, make its way through the heart, and then be pumped into the lungs. And it's really amazing when you see these things on CAT scan, to diagnose a blood clot in the lungs, something that we call pulmonary embolism. We do a CAT scan to look at that, and for those people with very, very large clots that break loose and go up, sometimes that clot can take up a tremendous amount of the circulation that's actually going to the lungs, and that's why people die. I mean, people die suddenly from pulmonary embolism, and that's why it's so tremendously important to start therapy early on if somebody has a DVT, because if not treated, then a significant number of those people are going to go on to develop a pulmonary embolism, which may or may not be fatal.
Are you finding sometimes that people have in their bodies or in their legs multiple clots?
Yeah. Typically, if somebody develops a DVT, it's in one area. A lot of people will come in and say, "Oh yeah, I had, my doctor told me I had 3 blood clots." Well, probably what that means is that there was one clot, but it may have extended through 3 different levels or 3 different veins. But if you develop a blood clot, usually it's in one contiguous area throughout the venous system of the leg. What I'm
getting at is I don't want people to panic.
Yeah.
However, I do know that particularly now, and if you're far away, modern air travel has made it so easy. You can be on the other side of the planet in just a number of hours.
Yeah.
But when you said that it is something that if you know what a symptom is, if you've had one before, you're more likely to say, I'm not going to wait for a week when I get back to Dr. Juliff's office.
Yeah.
I'm going to go in there.
Right.
How much interconnection would there be? And I'm sure that there have been times in your career where somebody has called you and said, we have a patient of yours here that has an issue.
Yeah.
Can we get some information about him?
Sure. That happens periodically, definitely, especially for people who are traveling, primarily inside the country. I mean, if somebody goes outside of the country, then, very rarely is a, foreign doctor going to call back. But at least that person, if they're traveling out of the country, they need to be evaluated somewhere, and, they need to go to the closest reliable sort of place where they might be able to have an ultrasound and get therapy going if they need it. But with respect to, those situational things that people find themselves in that make them more, susceptible to blood clotting, like we talked about, planes, cars, trains, etc. But the other place that is so very important are hospitals. Mm-hmm. People go into the hospital
for one reason,
for an unrelated reason.
Hip surgery.
Yeah, well, perfect example. Yeah, definitely. But even just for some medical problem, for a lung infection or whatever. But the first thing that we do with people when they go into the hospital is we throw them into bed.
Yeah.
And they in that in and of itself is an immobilization situation. Well, luckily we the country had I think there was a tremendous awareness about in-hospital DVT 10, 15 years ago, and luckily over the course of the last 10, 15 years, hospitals have developed protocols that protect patients, or they're given medications to protect patients from developing a DVT in the hospital. But that was a tremendous problem for a long, long time, and still is, quite frankly. When we're not on top of the prophylactic treatment for DVT in hospitalized patients, because not only are they immobilized, but they're also there often for other reasons, like lung disease, heart disease, that in and of itself makes them more susceptible to DVT.
What about when a patient finds out, and you diagnosed me? I just got off a plane. Somebody said, you got to go to Vein Clinics of Hawaii. I go to Vein Clinics of Hawaii, and you say, yep, you got a big old blood clot right here.
Yep.
Okay, what's the fix? What are we going to do with this thing?
Well, usually we don't do anything to it. Now, can you do something to it? Yeah, you can. And I'll talk about that in a second. But most importantly is the patient needs to be on a blood thinner. We try not to put people in the hospital anymore. Back in the old days, people used to be again thrown in the hospital, started on a blood thinner, and they were their legs were elevated and this kind of stuff. Well, we found out that actually, again, that immobilization was not good for them. Yeah. So we try to keep people out of the hospital. We start them on the blood thinner, and one of the good things about the newer blood thinners is that you can start it orally, and it's effective in a very short period of time.
Gotcha.
In the old days, we used to have to put people in the hospital, start them on what's called a heparin drip, and that was an IV medication that we started people on in order to get their blood immediately anticoagulated or thinned, and then we started the Coumadin. And the thing with Coumadin is that it's not effective quickly. It takes several days for Coumadin actually to become therapeutic. So we had to do this little bridge of heparin, which required the patient to be in the hospital because it was an IV. Well, with the newer medications, it's been a whole different world because we haven't had to put them in the hospital. You start the medication, your blood becomes thinned over a relatively short period of time, and the patient can then go home, be active. And the other thing is that it's fairly important to get that person into compression stockings. So we like to do that right away too.
You know, I want to tell you, gang, this we are about 40 minutes into this program, and that's the first time Doc's mentioned compression stockings. And if you want to talk about being proactive and working on your own well-being and your own comfort, once you find out how to put these uncomfortable things on and get used to them, your life changes. I mean, even my wife does all the time. I'm so proud of you for putting those things on every day. I don't know what turned the corner for him, but it's like, you know, How bad would you be if you weren't allowed to brush your teeth for a couple of days? It gets you pretty angry. Yeah. You know, but this is the same thing. So that's part of the thing but you said something else, and that is a lot of these things that used to be really debilitating. You'd have to go into surgery right away. Back in the day, before ultrasound and these other things, didn't they have to do a lot of exploratory stuff to find out what was going on?
Well, we had to do a lot more invasive testing.
That's what I meant.
We didn't necessarily operate on those patients for DVT, but back before ultrasound was of the quality that it is today, we had to do angiography. We had to do we had to put an IV in somebody's leg and shoot dye into the vein and
watch it on the screen.
Yeah, watch it on the screen and diagnose DVT in that way. But that was it was an invasive sort of examination and a little cumbersome. Certainly time consuming, and it's been so nice to have something like ultrasound be developed the way that it has, because it's a 10-minute deal. I mean, we can have somebody come in the office, and within 30 minutes we know, whether they have a DVT or not.
I think it's incredible. And also, Doc, you mentioned earlier, and I'm sure people want to know like me, as we talked about this coronavirus and there being nothing that you can take to not get it, and once you've got it, there's nothing yet that's going to help it get cured, except your own strength. And I'm guessing if you have a lot of venous issues, the more you take care of getting some of them treated, the less you're going to need additional treatment. In other words, I'm sure you've seen people who come in and virtually their venous system is the hell in a handbasket. They've just got all kinds of issues. Where do we start with that person, getting them back on the road to better health and mobility? Yeah.
Well, we diagnose what they have, and we just kind of work through it in a stepwise fashion, and sometimes it takes a while. There's no question about that. People who have real extensive disease, especially those with more advanced forms of venous insufficiency, with skin problems and ulceration, et cetera, chronic swelling. It can take a while, but we just kind of get through it in a logical, stepwise fashion. Hopefully get them to the point where they're stable with it.
What I kind of like, gang, those of you that I've spoken with and myself, I feel a lot more confident that, okay, I know I'm at risk, and if I get a symptom, I know that it really, really, really would pay you. As soon as you become symptomatic about something, go make an appointment and get it looked at.
Now, with respect to treatment, what I mentioned before is that's kind of the standard way to treat. We put people on anticoagulants, compression stockings, tell them to stay active as much as they can, and treat it in that way. Fully evaluate them with ultrasound, etc. You mentioned before, do we ever do something more than that? Well, yeah, every now and then. It's not common, but there are medications that will actually break the clot down. The routine blood thinners that we have don't actually work on the clot to dissolve the clot. Okay. Basically, what it's doing is, like I've mentioned a couple times, it's not allowing that clot to get bigger and
form, maybe,
propagate.
or a new one form, maybe.
Or a new one form. form. Yeah,
that's interesting.
So, basically what happens then is that, we put the patient on the blood thinner, and then over time your body starts to break that clot down. That's how it resolves.
Mm-hmm.
Now it resolves to a different extent in everybody. Sometimes we do ultrasounds on people with blood clots that have been treated with anticoagulants, years later, and there's no evidence whatsoever that they ever had a blood clot. That's good. Other people, however, unfortunately, we can see still residual kind of clot in there. And is it really blood clot? No, it's very dense and fibrotic. It's more of a scar than anything. But, and unfortunately, one of the things that can happen in people who have had deep venous thrombosis is that it can affect the function of the vein itself over a long period of time. So, maybe before they had the blood clot, the valves in the veins were working fine, the flow was normal, and all that. They were working well. Well, then they have the blood clot, and it doesn't resolve completely. It affects the valves and the function of the vein, and then they are left with a fair amount of venous insufficiency in that deep vein.
Wow. Okay, wait. I got this. This is the one I've been dying to ask for a bit now. I do know that when you get diagnosed and you start a treatment plan, that there's predictable how long it's going to take and how many procedures you have to do. But it looks like this one it really needs a little bit more urgency. What we're talking about is that's why there's all those disclaimers that you hear. May cause this and may cause that when you look at side effects of drugs.
Yeah.
But from what you're saying is there's really no preventative way to get ready for this diet or any otherwise. But you did mention that once you've had a clot, when you keep taking the medicine, that's to have your blood a little bit thinner so it's not as likely to clot again?
Well,
is that why you have to stay on it for sometimes?
It's not as likely for that specific blood clot to get worse, to get bigger, to break loose, etc. Then, the second question then is, are we treating just this blood clot? Or are we treating a condition of the patient that makes them more likely to clot? And are they then that much more likely to have further clots in the future? So we might need to leave them on anticoagulation for a long.
But that's a call that you would make based on the severity of a clot and what it took to fix it.
Yeah. Well, no, that's based on our further investigation of that patient and trying to determine whether they have an ongoing reason that's not going to be changed to have further clots in the future, like an inherited, reason for blood clot, inherited thrombophilia.
Yeah, and so it's not the end of the world. I mean, you got a pretty good grip on these things.
Yeah. And so then, are there ever other things we might do? Yeah, there are medications out there that will dissolve clots. The standard blood thinners do not. But in some very specific situations...
It'd be pretty controlled, wouldn't it?
Well, it would. Well, yeah, it's very controlled because if we do, and that's called thrombolysis or a thrombolytic medication. Now, is that a pill? No, that's not a pill. That's a situation where you go into the hospital. You can either start an IV and administer the drug, what we call systemically throughout your entire body. Sometimes a patient will then go into the hospital and they will have a catheter placed, a tiny little tube placed directly into the vein where the clot is. Okay. And the tube is now, and then the tube is infusing this, thrombolytic medication, a medication that's going to dissolve the clot. And that catheter is directly into the clot. We put it directly in the clot. So
was that technique or that modality ever even available when you first started?
The technique has gotten better over time. There's no question about that. But thrombolytic therapy for DVT has been around for a while. Yeah. Okay. But there are risks with that. I mean, again,
here's the 20 seconds of this might happen.
Yeah, like anything else. Well, and the main risk is bleeding. So we don't. It's not something that we would do in the elderly, or it's not something that we do in people who have some reason to have bleeding otherwise, like gastrointestinal kind of problems. But in some situations, again, it can be good. We usually use it in situations where clots are big and they're higher up. So if it's a very big clot in the upper thigh and pelvis, then we would think about doing thrombolytics with respect to trying to get rid of that clot completely. Because the clot that then sticks around, there are negative repercussions from that over a long period of time.
Okay, here's one. I'm not sure that I've asked you this before, and that is when you're taking a look at these things, and what damage they can do if they don't get treated.
Yeah,
it really makes one want to think, and yet we keep saying, all right, when you talk about don't not take the medicine. In other words, the other day I had an antibiotic given to me by my dentist, and it was because I had a dental infection. Well, it didn't hurt anymore, and so, but he said, I know where you're coming from. Take the rest of that stuff.
Yeah.
And isn't that the same on some of these medications that you will have?
Oh, definitely.
Well, the throbbing went away, Doc. Do I still have to take these pills?
Yeah. Exactly. And yeah, I mean, well, there's many situations in medicine where that would apply, but antibiotics are definitely one of them, and also blood thinners is another one. You just kind of have to stay the course and make sure, because there's usually a reason why your doctor is telling you to stay on a medication for a specific period of time. So.
Yeah, okay. Now, that being said, before we finish up, I want to remind you again, it's veinclinicsofhawaii.com, veinclinicsofhawaii.com. Dr. Juleff is the medical director, and you can certainly make an appointment by calling up, or easier yet, just go to veinclinicsofhawaii.com and click, and we will get in contact with you. And if you want to hear something on this show, we do that too. We do mailbags every now and again.
Yes.
Okay, so this program, Deep Venous Thrombosis, sort of a little a learning curve that I learn new things every time we do this. But I'm hoping that if people want to know more, that they would take their time to get an examination. What sort of symptoms would make somebody think? We talked about this a little bit more, but here at the end of the show, what symptoms might be the suggestion that you have a deep vein thrombosis?
Well, like we mentioned, pain and swelling are the two main ones. But I think as important as those symptoms are, probably the situation that they're occurring in is as important. So, again, I think that, we've often talked about people on planes and their increased risk of DVT. So if you're on a long plane ride and you have symptoms having to do with your legs when you get off of that plane, then it's worth looking into, definitely.
There are some people that are told, you might be thinking of, instead of traveling to go see the grandkids,
sure,
fly the grandkids over to visit you.
Right.
There are some times where it gets to a point, isn't it, that travel is just not a good idea.
Yes.
Yeah, for a number of reasons, not just the DVTs, right?
Absolutely.
Yeah, pretty interesting. And that being said, I do know that you've both said good and not so good things about the internet. Sometimes if you just Google swollen leg,
yeah,
and if you start, don't click send this tonic, right?
Right.
So, but isn't that the way a lot of people will make an appointment and just say, hey, I saw this on TV, or my friend had this, and I think I've had this, and let's do a little consultation.
Oh yeah. Well, we hear people come to our office via word of mouth from their friends, et cetera, all the time. Which is a good thing, anything that's going to heighten their awareness of potential problems that can be, in some situations can be life-saving, for gosh sake.
And that's what it's all about. Generally, and in future programs, we'll continue to do Circle the Wagons and come back to this. A lot of times we just do things that is going to make you a little bit happier. And one last plug for those of you that haven't, you go to Vein Clinics of Hawaii, my office here in the Ala Moana area, and get those compression stockings. They make a world of difference. I mean, not only are your legs svelter, but they don't hurt, which is kind of a nice thing.
Right.
Too. Okay.
Yeah.
Thanks, Doc. And if you want to know a little bit more about Dr. Juleff and the staff and the procedures, I would urge you to go to veinclinicsofhawaii.com, veinclinicsofhawaii.com, and you'll figure out a way to make your life a little bit happier. That's almost a guarantee. And by the way, there is no such thing as a silly question. And in our next programs, in the next few programs, you're going to meet people just like you. And this is an equal opportunity, problem that it happens to young, old. Most of us that are getting a little older have to worry about it a little bit. But don't feel bad if you start getting these lumps and bumps. Don't worry. There's light at the end of this tunnel by going to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. Have a great day. We'll see you next time for our Vein Clinics of Hawaii show right here on the radio.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.